Good morning, good afternoon, good evening, and welcome to the session on HIV self-testing, empowering people who inject drugs and increasing access to HIV testing and care. It's a huge privilege to be part of this session. It's something very close to my heart. I coordinate HIV, hepatitis, and STI testing, prevention and population work at the World Health Organization in Geneva. So why self-testing for hepatitis C, and why particularly for people who inject drugs? We have a lot of experience in the HIV world of HIV self-testing, and we found that it's a hugely empowering way for people to learn about their HIV status and link to treatment. And in the same way, self-testing for hepatitis C is just taking off. We're very hopeful that it will also be an empowering way to support people who could benefit from diagnosis and treatment, to have an additional way to support this. And why this session for people who inject drugs? There has been some work on people who inject drugs and hepatitis C, and that will be presented today. But as we all know, people who inject drugs do have a much higher burden of hepatitis C and are very much left behind at the moment as we increase coverage of curative treatment. So let me just outline what's going to happen today. We're going to have 3 presentations, and then we're going to move into breakout groups to discuss some of the issues related to hepatitis C self-testing, and generate some ideas about how we can take this forward. But as we go along in this session, please do put questions in the chat, because after the presentations, we'll have a live Q&A. I'm going to introduce the first speaker, who is a very dear colleague of mine, Dr. Niklas Luhmann. He's a medical doctor with an MSc in International Public Health from the University of Berlin. He's been working for more than 10 years with different institutions on access to healthcare, with a focus on HIV and viral hepatitis, particularly related to prevention, testing, treatment and care in vulnerable populations. He joined WHO headquarters in Geneva in 2019, where he's really led the work as a technical officer here on viral hepatitis prevention and priority population work. So over to you, Niklas.
Yes, thanks so much, Rachel, for introducing me, and I'm very happy to join again the INHSU conference. Unfortunately, it's still virtual, but very happy to give the intro talk here on hepatitis C self-testing. And thanks, Rachel, for all your year-long leadership on self-care and HIV and now hepatitis C self-testing and we will have 2 other presentations before we start really a dialogue with our participants in the breakout groups. Hi, everyone. I will just talk to our new guidance. We have now released earlier this year the first ever global hepatitis C self-testing guidelines from WHO, and I just wanted to show you this new guidance and the evidence behind it quickly before handing over to Sonjelle. So I think possibly everybody knows that slide, but I'm still showing it because it is somehow the background framework for everything. WHO defined elimination of viral hepatitis by 2030 as a 90% reduction in incidence and 65% reduction in mortality for hepatitis B and C when comparing to a baseline in 2015. In terms of testing and treatment access, it was defined that the target of 90% of those living with chronic hepatitis C should be diagnosed, and 80% of eligible people with chronic hepatitis C treated to achieve those targets. And where are we now? This is a slide from the recent progress report on HIV, viral hepatitis, and STIs that we released, and that has some new estimates on the cascade and the prevalence. So maybe look here at three main messages. One is in the title, that is a new estimation of how many people actually globally live with hepatitis C, and that was estimated at 58 million, which is a little bit lower than previous estimates. The other messages are in the graph, where you see in green the percentage of people that are hepatitis C infected that are estimated to be diagnosed in 2019, and then in yellow the percentage of people that are infected estimated to be treated. On the left you see the global estimate, and so there is 21% of all people living with chronic hepatitis C estimated to know their infection, and then 13% only to be treated. Obviously very far off the track, and with a huge gap as well in testing, and that's what we're going to talk about today. Obviously, you see on the other bar charts or the other bars the WHO regions, with the Eastern Mediterranean one performing a little bit better and the African region being the further behind in terms of those access and coverage targets. So we do have a really important testing and treatment gap that we want to close. What have we recommended in terms of hepatitis C testing in the past? Without going into much detail here, please just see the guidance summary from 2017 in terms of hepatitis C testing. In the first kind of line, you see who to test, and that we recommended a mix of focused and general population testing, so most affected populations and general population testing in some settings, and for some settings consider birth cohort testing. What did we say on how to test? That was really facility-based single serological assay, so an RDT for antibodies of hepatitis C, and then in case of a reactive serology to look for viremia to confirm active infection, or with a nucleic acid testing for ANR, or for with a core antigen. And so hepatitis C self-testing obviously comes in, or maybe not obviously, but comes in as an addition to a serological RDT, so to speak. So looking into the presence of antibodies. Here is the recommendation we developed, and then I will show through two slides how we get what evidence we generated and how we interpreted it. So the new WHO recommendation, and this is the first time for hepatitis C self-testing, says that hepatitis C self-testing should be offered as an additional approach to Hep C testing services. We added three, and this is a strong recommendation made by the GDG with moderate certainty evidence. We added three remarks that we wanted to highlight some messages in the recommendation, or very close to the recommendation. One is around the importance of including self-testing in an overall service offer for hepatitis C that includes linkage, confirmatory testing, and diagnosis and treatment access. We wanted to highlight as well that it is desirable to adapt self-testing services to context and community preferences. And last but absolutely not least, that communities, and including those from key populations, should be meaningfully involved when it comes to developing, adapting, and implementing those services. So this is our new recommendation that we wanted to share with you today, and for which we want to have some discussions more on the implementation side. How did we gather, and what evidence did we gather? So really, this is a puzzle of 4 pieces. One in blue was a systematic review for hepatitis C self-testing. We updated in green the HIV self-testing systematic review. We had studies from FIND that Sonjelle will speak to, certainly in orange, that are community-led values and preference studies, and Danil will talk to that as well, and then usability and acceptability studies that informed as well the evidence piece, and FIND commissioned as well in collaboration with us a cost and cost effectiveness model from Bristol University. And those pieces were brought together and looked at to analyze the 4 pillars that really make up for WHO recommendations around effectiveness and benefits and harms, values and preferences, feasibility, and resource use. And this is what we found. Interestingly, we didn't find any direct evidence for effectiveness of hepatitis C self-testing, and that thus we use the HIV self-testing evidence from 27 randomized controlled trials as indirect evidence. And those show, as you might know, since many years that self-testing increases uptake, allows for many people to get diagnosed, has good linkage rates, and very low social harms or misuse reported. We had direct evidence for values and preferences and usability and cost effectiveness, as I said, as opposed to the effectiveness evidence where we did not have that. And those showed, and we will hear more, I'm sure, later, but those showed that people are willing and able to perform a test, that it's acceptable, that it may increase equity, and that really, in terms of resource use, it will be much likely a little bit more expensive per diagnosis, but this approach would really allow us to be an asset in terms of diagnosing more people and supporting closing this diagnostic gaps. Self-testing will not be the only additional step we have to do to increase diagnostics access, but it can be a really very interesting additional tool, as Rachel has said in her intro and the experience from HIV. I don't want to go into detail with this one, but our guidance has a nice chapter on implementation considerations where you can find those major points, and this was developed to guide really countries in developing policy, community engagement, and a quality assured approach. More in the guidance, I just wanted to orientate you towards that. It includes as well a chapter, or within the same chapter, some narrative around the major service delivery models, and I think we will have some time to maybe discuss them in the breakout rooms. But really, self-testing can be used through many different pathways, from more facility-based to very community-based, pharmacy-based, or even using online, and it can go as far as having secondary distribution, which now has emergingly been nicely shown in HIV self-testing, for example. And here are the tools that might be supportive and that can be used. Again, just to orientate you to that list, and we'll have a breakout group just on that. It can come really from more, let's say, intensive in-person to video supported or just written support tools to really allow people to perform the test correctly and then link to care. What are the next steps? I just wanted to show very concretely, and I hope Sonjelle can comment a little bit about some of those as well, is really to think about what comes next. In terms of product pipeline, we don't have a stringent, don't have an approved test that is approved by a stringent regulatory mechanism yet. We hope that we soon receive submissions for WHO pre-qualification. We know that there are promising prototypes as well for oral as well as for blood-based self-tests. And we know that the Global Fund-specific ERPD mechanism has allowed for manufacturers to submit self-tests, and that we're hoping for first results in very few weeks. I wanted to highlight as well that there are different pilot projects and research projects in real-world settings that will be developed with a portfolio discussed now by the STAR Unitate partners that have strong experience in HIV self-testing, with 3 research pilots from FIND. As well, you see the countries in blue listed here for those different ones, and the CDC, WHO, and FIND collaboration as well in Georgia in the general population, with 2 distribution models that will be evaluated, and possibly more to emerge, for example, in India. Here are the links to the resources where you can find the materials that I've shown, as well a community video that FIND has done and on our webpage. I wanted to acknowledge all our WHO colleagues under the leadership of Rachel, and the Fund and all the other partners that have contributed so much to these guidelines. Thank you very much, and I'm looking forward to a great discussion.
Thank you very much, Niklas. So now you know WHO has recommendations on HCV self-testing, and it's really all about action now. But I'm going to turn now to how we manage to make those recommendations. We can't make recommendations out of thin air. So I'm really pleased to introduce the second speaker here, Sonjelle Shilton. She's going to talk about her work on the usability and feasibility studies that she's been involved with for hepatitis C self-testing for people who inject drugs. Sonjelle is a public health specialist focusing on operational research for evidence-informed policy change at national, regional, and global level. She joined FIND, which is the Global Alliance for Diagnostics, in 2017. And she's the hepatitis lead there. She's responsible for planning, organizing, and implementing the viral hepatitis portfolio, from upstream research and development of emerging technologies to piloting and scale up of innovative new diagnostics. Sonjelle started her career in public health as Director of Operations of a CBO in rural Ghana, and she has over 15 years' experience of leading programs and implementing science studies, including this work on hepatitis C self-testing. So over to you, Sonjelle. Just before just to remind you, please do put questions in the chat. We really want to be able to respond. We're really keen to hear from people who are thinking about self-testing in their countries or have already some experience. So please, we want a lively discussion. Thank you. Over to you, Sonjelle.
Great. Thank you very much for that introduction. And I am pleased to be with you today. So I'd like to thank all of the attendees for joining us in this session. And as Niklas has done a nice background, I will jump in and the usability and feasibility among people who inject drugs. And I'm presenting on behalf of the entire FIND team. Next slide, please. So just a quick note, when we are talking about hepatitis C self-testing, we are talking specifically about the first test, the antibody test, to see if a person has been exposed to hepatitis C. Next. So self-testing in general is when a person collects their own specimen, in this case, oral fluid or blood, and then performs a test and interprets the results. Next. And it's often in a private setting, either alone or with someone they trust. Next. So some important points about self-testing. Next. Okay, so we had a technical challenge and my slides were my computer was not cooperating today. So the formatting has gotten a little bit wonky. But the first thing that I would like to say about self-testing is, as Rachel and Niklas have already well stressed, the self-testing is not here to replace other testing modalities, but rather it's intended to be a complementary. It's an additional tool in our toolkit that can help us reach the testing numbers that we need in an equitable manner. Also, it's not a definitive test, but it's rather a first step towards learning a status. Next. And as Niklas well highlighted, it's currently research use only. There are some promising tests in the pipeline, but we are waiting for them to come to market. Next, please. All right, so now we'll talk on the evidence. So these are some of the evidence packages that went into that WHO decision. Next. So what we did a series of pilot feasibility studies in a variety of different countries. Next. We did oral fluid test feasibility and acceptability among men who have sex with men and people who use and inject drugs. Next. And then we did blood-based and oral fluid test feasibility and acceptability in several populations. Next. And then blood and oral usability. Next. I like animations a lot. So what we'll be focusing on today is the 3 studies that look particularly at people who inject drugs in Georgia, Kenya, Vietnam. Next. It's going to flash. Next. Great. So the countries and settings, as we already mentioned, it's in Georgia, Kenya, and Vietnam. And these studies were done either in community-based organizations or in harm reduction sites. Now, it's important to stress that the study design was what's called an unassisted testing model. So basically what we did was participants enrolled in the study, we showed them the instructions for use, and then we said, okay, please conduct the self-test. We had a study staff standing and watching the participant conduct the self-test, noting down in a structured questionnaire where the participant had problems, and if the participant said to the study staff, please, I need help, I'm confused, or if they were going to do something like drink the buffer fluid, which almost happened, then the study staff came in and said, nope, okay, we can't, that's, let me help you facilitate this process. And then after the test was completed, then the participant read the test results, and a study staff member who was not in the room during the testing process came in and also read that same test to see if the test result that the participant had read, it was the same as the test result that the staff trained in the professional use test had read. Additionally, then another staff member performed the professional use version of that test on the self-testing participant. So this was to see if the results from the self-test aligned with the results from the professional use version of that same test. And all of these tests, all of these studies were done using the oral fluid prototype by OraSure. Next slide, please. So here we see the instructions for use. So these have been further optimized. Just as with HIV self-testing, initially the companies produce instructions for use, and then through refinement and studies in the field, they optimize these instructions for use for maximum understandability and usability. Next slide, please. So here we see in the results from the unassisted testing model. And what we can see is that while a lot of participants did require some assistance, and it ranged from around 30% to up to 71% of people who were able to complete all testing steps correctly. Given that, though, if you look at the second to last line of interpreted results correctly, we see that a high majority of participants were able to interpret the results correctly, and did have agreement with the professional use test. So what this shows us is that some of the testing steps that participants had difficulty with were not what we call like the critical testing steps. In oral fluid testing, there are 3 critical testing steps that have the most impact on the outcome of the test results. And the majority of participants were able to complete these testing steps correctly. Next, please. So basically, unassisted testing did lead to more frequent mistakes than what we saw in the assisted testing models, which we did not show today, done among the general population. However, the mistakes that did happen do not seem to have a major effect on the test results. Next slide, please. Next. So, or the colors, the color scheme has changed a little bit, but the majority of the people who inject drugs participants have conducted the critical testing steps correctly without an in-person demonstration. There was relatively high overall usability. So in the MSM, they had a little bit higher ability to complete the steps correctly. But this looks like it's mostly related to the fact that that population group tend to have higher education levels than the education levels that were reported among our people who inject drugs participants. Next, please. And then more than half of the participants who were injecting drugs in Vietnam and Kenya did require assistance to conduct the self-testing process. And they did make at least one mistake during the process. In Georgia, however, the majority of the participants who inject drugs completed all the testing steps correctly. So this just goes to show you that, as within anything, there's going to be differences among each context, even among, same population groups. Assisted self-testing models may be considered for people who inject drugs population in early implementation. And this is really important, right? So as we said, those 3 studies that we're presenting, they were an unassisted model. Basically, we gave the instruction for use and it said, okay, go for it. However, what we need to understand is what are the results when people who inject drugs are provided an assisted model. So we'll be working with colleagues in Kyrgyzstan to look at what happens when we offer the participants a demonstration before the testing process. And we'll see, what the usability, what the alignment, and what the ability to complete the steps correctly will be in that. And hopefully that will help to fill some evidence gaps. Next slide, please. So what's next? Well, I talked a little bit about the Kyrgyzstan study, where we'll be looking at the assisted model, the feasibility and acceptability of an assisted model. Next, please. But we'll also be looking on the evidence on uptake, linkage, and cost. So as Niklas well mentioned, we are looking at 3 uptake and impact studies now. Next. In Georgia, next. So we'll be looking at an online model. We'll be integrating hepatitis C self-testing into an existing online platform that exists for HIV self-testing. Next. And we'll be looking at understanding linkage to testing uptake and linkage to care. Next. It's a 5-arm randomized controlled design, because we're looking at both people who inject drugs as well as men who have sex with men, and we're looking at postal delivery of the test compared to pure delivery of the test compared to a standard of care. And we estimate to enroll 1,200 participants. Next. I guess next again. There we go. Next. All right. And in Malaysia, it's quite similar. Next. With similar objectives. Next. And it's just a randomized control design. In Malaysia, we'll be looking at the oral fluid test, the blood-based test, and then compare that to the standard of care. Next. Estimate to enroll 750 participants, and it's using both the blood and oral, as I said. And we've enrolled about 174 participants, I think, as of yesterday. So that's coming along well. Next, please. Then in Pakistan, we'll actually be looking at secondary distribution among the general population in the context of an ongoing microelimination campaign. Next. And so here we are looking at uptake, but we're also looking a lot more about cost and feasibility. Next. And it's a cluster randomized control. And next. All right, next. So I'd like to thank everyone, and I'm excited to hear for our next presentation. Danil is going to be talking about the values and preferences, and particularly that was from the Kyrgyz experience. But I just want to highlight that this work was part of a large 10-country study. And so we'll be happy to get that deep dive. And I'm keen to answer any questions. Thank you for your time.
Thank you very much, Sonjelle. And as I said, WHO relies on studies and evidence coming from these studies to help us with our guidelines. And so all the work that Find did was absolutely critical for us to be able to make this recommendation on HCV self-testing. And I think it's really critical to recognize when you introduce a new product like self-testing for hepatitis C, it's not going to be the same for everyone in every place. And I think so many lessons about how we can support us with product introduction. And we've learned a lot from HIV self-testing, that at the beginning, people will find this new, but as communities begin to learn and this becomes more of a much more available, people can do this much more easily. And I'm also reflecting on COVID self-testing that's now available in many countries. Who would have thought, that has taken off so massively, and people are really now successfully being able to do that. So I've got huge encouragement for hepatitis C self-testing being feasible and effective for people who inject drugs. as Sonjelle said, WHO also really needs to understand the values and preferences of communities. There's never any point in WHO making a recommendation unless the end users of a product feel that this is something that will be useful to them. So the work that that Danil and colleagues have done on the values and preferences has been an absolutely critical part of our guidelines process. So it's a huge pleasure that I now introduce Danil Nikitin. He's from the GLORI Foundation. He has represented the Global Health Research Center of Central Asia since 2007 and has headed the Global Research Institute since 2011. He earned his master's in social work from Columbia University, and after graduating, Danil returned to Kyrgyzstan as director, PI, and co-investigator, and he's led research focused on gender-based violence and HIV prevention in drug-using communities. So over to you, Danil.
Thank you so much, Rachel. Thank you, friends. So I'm going to tell you about findings of the assessment that we conducted in Kyrgyzstan. Next, please, Heidi. While Kyrgyzstan was one of the countries mentioned by Sonjelle and Nicholas, so the assessment was really success. It was due to effective collaboration between the Kyrgyz Harm Reduction Network Association and the Kyrgyz-based GLORI Foundation. We would like to thank Mauro Guarnieri and Hilary McHugh of International Network of People Who Use Drugs for all their coordination and advisory effort that they have applied with our team. We appreciate Sonjelle Shilton's and Dr. Guillermo Martinez Perez assistants, who have been generously sharing their time, experiences, and energy for providing methodological supervision to us. We are very grateful to drug policy reform advocates and activists from Kyrgyzstan and other countries for their work. We are grateful to all project informants for their responsiveness and willingness to participate in the project. Without their commitment and desire, the results achieved would not have been possible. Well, many thanks to the INHSU organizers. We all know that people all over the world will benefit from the products and services that will be developed using the data that we have collected and are presenting. Please, next heading. Thank you so much. So Kyrgyzstan, really small country. So it borders on China, borders on Kazakhstan, borders on Tajikistan, Uzbekistan. So in Kyrgyzstan, HCV prevalence it is around 3% in general population and more than 60% in people who inject drugs. The harm reduction network was subcontracted by International Network of People Who Use Drugs to conduct a rapid qualitative assessment of values and preferences of HCV self-testing among people who use drugs in Bishkek, it is the capital town of Kyrgyzstan, and Chuy region. So the assessment started in August 2020 and ended in the end of October. The Kyrgyz work is part of the broader assessment. As Sonjelle mentioned, so we all use the same global protocol so that the findings we could synthesize the findings later. Next, please, Heidi. So, yeah, thank you. Project lifestyle. Well, the assessment, there were three phases, like traditionally, preparatory phase, implementation phase, and wrap-up phase. So the work scope was split into three phases, and the assessment of values and preferences was carried in following attributes: awareness and attitudes, acceptability, modes of communication and deliver, challenges and concerns, supervised versus unsupervised self-testing, affordability and packaging, and change in risk behavior. Next, please, Heidi. So study population, these were the eligibility criteria, described in the protocol that we strictly followed. So people had to be no younger than 18 years old. They had to speak and understand Russian. They had to self-identify as people who inject drugs. They had to have some HCV-specific experience and knowledge useful for operational purposes. They had to be able to complete informed consent, and they had to be willing to share their insights to improve operations. Please, next heading. Thank you. Data collection techniques. There were 18 encounters. So face-to-face individual semi-structured interviews with 15 people, group semi-structured interviews, so there were two groups discussion, and participatory exercises, so there was just one activity like that. Please, next, Heidi. Here are the results of social demographics. So I will not go like in details into this slide, but just, well, I'm so proud that we were able to to enroll not just male drug users, which is, well, let's say it's easy, it's traditionally easier to get in touch with male drug users, but we also were able to enroll almost the same number of women who inject drugs. We were able to enroll people with incarceration history. We were able to enroll people who are not direct beneficiaries of harm reduction programs, but are kind of secondary beneficiaries. So which is an advantage. I mean, now we were able, well, with this diverse population, we were able to really collect lots of useful information. Please, next heading. Awareness and attitude. So the interviewed people who inject drugs demonstrated proper awareness with respect to the concept of hepatitis C. They used to compare, well, they used to use actually the terms associated with HIV self-testing, which was nice. Acceptability. All informants appreciated the idea to allow people to self-test for HCV, since this innovation would give them the flexibility and opportunity to get tested at their own convenience, even in the time of lockdowns, which is very important. Please, next heading. Thank you. Results. So, yeah, modes of communication and deliver. Well, the government clinics were suggested, the private clinics, and of course through harm reduction community-based NGOs. This was the priority option, which was offered by almost all the informants. So challenges: missing privacy and confidentiality. According to the informants, HCV self-testing also creates another risk to other people with whom they interact. Recommended support materials: leaflets, paper-based inserts, readable brochures, videos and video tutorials, online resource center and hotline available like 7 days, 24 hours, including based on interactive voice response. Please, next. So challenges and concerns. Finance issues. Well, it is important. That self-tests have to be affordable, which is always a problem with countries like Kyrgyzstan and with people who inject drugs who always have issues with employment. Well, discrimination by medical personnel. One of our participants, a woman who inject drugs, she's 35 years old, so she mentioned that whenever she applies to a lab, to collect blood, so the lab nurses, they always ask why her veins are so hard to reach. Well, when she openly says that she is a drug user, that she has drug using experience, so they immediately the hostility feels immediately. So they start asking her to go back to the corridor and to wait until all other people could be tested, so that she could do the same, but as the last visitor. Why this discrimination actually? Well, it does not make sense. Solutions suggested: friendly navigation by peers. Lab office hours have to be convenient to people who inject drugs. Not from 9 through 6 p.m., but maybe some different office hours. Brief counseling by a pharmacist. Introducing self-testing in prisons, it's for sure, it's necessary, but we do understand, we do acknowledge all the challenges associated with it. Like the regular self-testing actually, there is no yet self-testing protocol, but when it is available, we are sure that it has to be different for prison population and for general population who do not have all the prison-associated restrictions. Please, next heading. Thank you so much. So, top preferences: managing self-test alone with no further obligations. Testing with peer-supported community-based harm reduction NGOs, involving their siblings, relatives, and children in the self-testing process. Use online resource centers and hotlines. An online resource center with hepatitis C materials and information, it has to be available, and it has to be in several languages. So like in Kyrgyzstan, we definitely need something available in Kyrgyz, in Russian, and in Uzbek. Well, ideally in other languages too, but at least in these three. Well, enhanced communication with medical staff in clinics and necessity to disclose status was mentioned as a top necessity should people who inject drugs have to request confirmatory testing or treatment and care after positive HCV self-test. Next, please. Thank you. Affordability. To get self-testing for free, it is the top preference, of course. Oh no, actually the top preference was to get it for free and also to get some incentive to be engaged in self-testing, like in piloting self-testing. So then the second option was to get it for free, to receive certain incentives when the initial self-testing is applied, and as the least desirable alternative, paying maybe $5, maybe up to $7. Change in risk behavior. Availability of self-testing can provide necessary basis for awareness of people who use drugs own health status. While females were concerned about possible stigma from lab personnel engaged in follow-up confirmatory testing, and rural informants were more concerned about availability and about lack of privacy. Next, please. Well, just briefly about recommendations that the participants of the assessment suggested. The cost for testing services has to be covered by the medical insurance, and key populations have to be eligible to it. Very smart recommendation, by the way. Design the law on HCV that would be a little somewhat similar to the law on AIDS, on HIV and AIDS that many countries have now. So without this legislative platform, well, it's really hard to imagine that HCV will be sustained. HCV self-testing will be sustainable. But having this law would be very. Some sort of association has to be organized, kind of HCV association that would be independent body led by people with HCV and activists, similarly to Harm Reduction Network or Diabetes Association of Kyrgyzstan. Medical professionals have to be further trained to minimize stigma and neglect towards people with HCV. People have to be properly informed of diverse testing and treatment solutions. Harm Reduction Network and Community Advisory Board under the Ministry of Health have to mobilize civil activists, NGO leaders, and medical professionals for developing proper training materials on how HCV self-testing can be used. And efforts have to be undertaken to engage the Prison Management Authority for developing proper testing and treatment protocols applicable for in-prison framework. So, well, that's it actually, Hedy. Thank you so much. Thank you.
Hello. Hello, everybody. Now it's time for question and answer session. We have a bunch of questions and we need to prioritize because we are running out of time. First question I would like to ask to take Sonjelle. This is regarding media was used to provide instructions to study participants and if it has impact on outcomes of the study.
Yeah, that's an interesting question. I think that for hepatitis C, I can say we haven't done any specific work looking at the different media of self-testing, how it's presented and how it impacts. Although I do know that for HIV, particularly within the context of the STAR portfolio, they have done a good amount of work looking at different instructions for use and the like. So maybe I would turn it over to Rachel to see if she has any additional comments.
Yeah, no, I think it's all about listening to your communities and see what they find useful, and there will be different things for different people. Some people love to read instructions, others prefer to look at a video or just talk to a friend or have a friend just show them. So I think it's being really flexible and listening to communities and see what's going to suit them the best. And as I say, it's going to be something that will change over time. When new things happen, people need a bit more support, and that really has to be factored into programs. But certainly, you know, having in some of our programs, we've had TV series that have included HIV self-testing. So people really start to know that they can do that. And actually seeing somebody do that on a soap opera has been fantastic in Africa to support HIV self-testing. So we've got to think really, really creatively, using all the sort of new media and links that people can, but also recognizing that some people will just need gentle support from a peer for that first time that they do that.
Thank you. We have another question that I shall ask Danil to take. Question is regarding the importance of psychosocial support for those who will be tested with self-test, how it is important, and if it was explored during your study.
Ketevan, well, thank you for the question. Well, one of my colleagues who actually registered for this conference but was not able to connect because of the technical difficulties with this platform, she even asked me to highlight this. You know what? Testing as is does not work. So it does. It's hard to imagine that a regular drug user comes to a community-based NGO and is asking to get tested. No, something has to be done differently, and different approach is to just use SBIRT framework. So SBIRT, which stands for screening, brief intervention, and referral to treatment or to testing, to further testing. Actually, without motivational interview, it's hard to imagine that in real life someone just steps into a community-based NGO and is asking for testing. Well, why would we provide you self-test kits? Why? Who are you? So why? Do you have any? Well, I mean, well, but
you are highlighting importance of such intervention, especially if we are talking about a drug-using community. We have also one very quick question, and I would like Sonjelle to answer. The question is regarding that the studies explored only serology test, and there was no self-test studied for confirmatory RNA testing.
That's correct. In these studies and the studies that we're talking about, this is relating to the serological testing. However, there have been some studies, I believe in the Netherlands and a few other places, where they do explore self-collection, so dried blood spot self-collection for RNA testing. And I believe also in Australia, there was a study that was looking at that as well. So, well, what we're talking about right now is about the serological testing. There have been others for self-collection, but there's no platform really at the moment that would allow for like at-home RNA testing to do the testing yourself. Now with COVID and the rapid expansion of different technologies, maybe that's something in the future that might emerge, but not right now.
Technology is developing so fast. Who knows? Thank you. I think with this we can close the question and answer session, but participants, you can put your question in the window and our speakers will try to respond to you during the session. Thank you.
We're now going to move to breakout rooms, and this is really the most exciting part for us, us here. We really want to hear your views, and Niklas, my colleague, is particularly keen, as he's going to be he's developing a technical working group on HIV on HCV self-testing, because we don't want this to end here. We don't want. We've shown that people can access testing, they can do it. You know, there are lots of opportunities, but we just don't want this to go nowhere. So we want thoughts about distribution challenges. That's breakout room 1, and Sonjelle will be leading that. Breakout group 2 is on linkages. We want to support people once they've tested to link for confirmatory testing and treatment. And Michael Wilson will do that, lead that group. Breakout room 3 is on supportive tools for self-testing on people who inject drugs, and Danil will lead that. So I'm going to hand that over to the conference to tell us how to do the 3 breakout groups, and we need some really concrete thoughts about how we can move forward on these 3 areas. Great. Well, welcome back. I think, as has been said, it's a shame we're not all in person. It's not an ideal way to discuss these issues, but it's a start, and it's really great that we have you here for some first thoughts. I'm going to hand over now to the chairs to have some quick report back. These are really important for us, really important for Niklas as he takes his work forward. So breakout group 1 distribution. Do you want to give us a quick high-level feedback of what your group said?
Great. Yes, so we it was a really intimate group where we actually only had one person who was able to speak. The other attendee was not able to speak. And we were actually hoping to, the other attendee, Astrid, was hoping to learn from others' experience, because she highlighted that in the context in Berlin, that the majority of people who inject drugs, they are aware of their antibody status. So for them, it's more understanding the secondary linkage and stuff. So I think it was well highlighted to the other groups should also be considered, particularly in this context. Refugees or immigrants, people who don't have formal paperwork or ability to get within like the formal healthcare system. How could self-testing be a way to be that entry point? So that was kind of our bit in a nutshell. Thank you.
Thank you. Breakout group 2 on linkages, really critical. Over to you, Michael.
Great. Yes, we had a very quick, very good discussion. I wish we had 10 or 15 more minutes. But yes, we spoke about one in particular area that could be utilized is around peer navigators and just the relationship that peers have in trust and connection to provide support. And there's various models of that's already being used. We're actually using peers in South Africa to deliver medication, chronic medication, to individuals who are staying on the streets, who are not yet coming into harm reduction centers. We also spoke about potential avenues for people accessing self-test, including one of the ideas was using vending machines. Vending machines are being used for HIV test, and so vending machines could be used. Also, engaging partners of people who inject drugs to find their partners, but also to encourage them to be tested as well. So yeah, we had a great discussion, and I think that there were some good points, and yeah, and I think that mostly it was really around the support that is really critical, and the accessibility to people, recognizing that time is a really important factor. So I think a variety of different strategies using both various centers, community centers, harm reduction centers, but also places in the community that we know people are accessing, that they can do it on their own time. So thanks.
Thank you very, very much. Thank you very much, Group 2. Really important insights there and things to take forward. And then our final group on supportive tools. So over to you, Danil.
Yes, thank you very much, Rachel. So our group was not so large, so we were able to discuss the issue of support tools, of designing support tools and designing the proper support rules, contextualized support rules. One of the first steps that Niklas suggested, it was like to start from providing just possibility to the community to be aware of self-testing, so that people just knew that self-testing for HCV is available, as well as self-testing for pregnancy, self-testing for HIV as well as another resource. So just being aware of it will be really a great step forward. So then Breen, the participant, she is a professional from New York. So she mentioned that, well, multiple stakeholders have to be involved in it. So including religious leaders, including community leaders, including political leaders. So, well, academia. So in Kyrgyzstan, we have a really good experience when drug users applied to Kyrgyz Medical Academy and asked them to help them to have developed clinical guidelines for curing disorders caused by stimulant drugs. And this was really a great step forward when drug using community leaders, they go to the academia and ask them to help them to survive a trouble. So that's really it can really cause a success. So well, Nicholas, you please now add.
No, I think I don't have much to add. That
Go
was
ahead,
the main points, Danil. Maybe one thing that our participant Bryn as well has brought in, and that was a little bit mentioned in the second group. That's the only thing I would add is ideas for collocating or distributing the tests. For example, when working with people on overdose management and prevention and so forth. So, you know, thinking about innovative ways or creative ways where it is best for people to distribute or to offer a self-test. But I think really our discussion was a lot around what you said, to raise awareness and demand is really essential, that people are aware that this exists and is available for them, and very empowering. Yeah.
I'm going to just be very, very brief and thank everybody, thank the conference for giving us this opportunity, and really say this is the start of a hopefully a really big process to get many more people access to hepatitis C testing through self-testing. And we really look at WHO, look forward to taking this forward, and Niklas will lead this. So thank you, and I'll pass on to my co-chair.
Thank you, Rachel, first of all, for great sharing. Thank you to WHO and Fund for organizing this very interesting session. Thank you, dear speakers, for presentation and your leading the group discussions. And thank you, Nikita and Olive, for great technical support. And first of all, thank you, dear participants, for your engagement and contributions. As Rachel said, this is only start. But we are happy that we found really big pieces into the puzzle of hepatitis C self-testing, but still some pieces are missing. And your experience, your knowledge that you shared today with us, I think, key to the success of rolling out hepatitis C self-testing. We are really pleased having you with us today. And we are leaving this session with the food of thoughts, how we will integrate, what will be next steps, what policy changes or system-wise approaches we need to use. So we are looking forward, and first of all, we are looking forward to approval of hepatitis self-test to starting implementation. Thank you once again for being with us. Have a good rest of day or night, depending on the time zone. Goodbye, everybody.
Thank you.